So my name is Tammy Walsh. I'm one of the current Harvard Emergency Ultrasound Fellows, and I am an attending physician at MGH and the Brigham and Women's Hospital in Boston. And I have the pleasure today of speaking with Dr. Zachary Stewart, who is the Director of Musculoskeletal Ultrasound at MGH. He is also appointed as an instructor of radiology at the Harvard Medical School. Dr. Stewart completed his musculoskeletal imaging and intervention fellowship at the University of Wisconsin. Dr. Stewart's particular interests include quantitative imaging, interventional pain management, interventional musculoskeletal oncology, and musculoskeletal applications of ultrasound. At WinFocus 2024, Dr. Stewart is going to be presenting his work on shearwave elastography for MSK ultrasound. Dr. Stewart, can you tell us a bit more about this topic and what it entails?
Yeah, sure. So, elastography for musculoskeletal ultrasound is a growing sort of niche within the world of musculoskeletal ultrasound, where we're trying to use quantitative information to gain insight about the mechanical nature of tendons and potentially be able to use that information to prognosticate how patients will respond to treatment or the condition of their tendon and hopefully be able to correlate it with patient outcomes. At present, there's a lot of research into the field, but things are not quite clear yet. And so one of the things I'm working on is trying to investigate that and hopefully shed some light on how we can use this clinically.
That's amazing. So for someone who doesn't know a lot about shearwave ultrasound, how is that different from like B-mode ultrasound, for example? Like how is it better for being able to visualize the tendons?
So with shearwave elastography, we essentially send acoustic radiation into a soft tissue structure, and tendons in their healthy form are generally quite organized, and so they're fibrillar in nature. And so when this acoustic radiation reaches the tendon, it propagates through there, and we can measure the propagation of these shear waves through our transducer. As tendons become less and more disorganized, what we end up seeing is that these shear waves do not move as quickly through the tendon.
Mm-hmm.
Now, if the reverse happens, if a tendon becomes stiffer, then you might see the opposite. And so that's where some of the challenges in shearwave elastography come from, because a sick tendon may be stiffer mechanically, or it may be less organized and sort of more gelatinous, in which they'll be slower. But the nice thing is that we're able to generate sort of a map on the tendon where we can see the different mechanical features of the tendon in different regions. And so that's sort of the advantage of shearwave ultrasound, is that we can see on a structural level a lot more than we can see with a traditional B-mode image.
I see. And then depending on the type of injury, then like, if it's like you said, there's more disruption or it tends to be stiffer, does that change management at all?
Well, potentially. There have been studies. One that was particularly interesting is in the rotator cuff, for instance.
Mm-hmm.
When they looked at patients that had rotator cuff tears and they evaluated them prior to surgery with shearwave elastography, they found that the postoperative outcomes, so patients who did well, had higher shearwave speeds, and the patients that were more likely to re-tear or have negative outcomes had lower shearwave speeds. And so in that sense, it could sort of prognosticate how people could do after rotator cuff surgery.
That's amazing. And is there one kind of part of the body that it works better at, or is it just really anywhere in the body? Like you mentioned.
I think it's not clear yet. I think we have to figure that out. There are obviously areas that have been studied more than others. The more superficial something is, the easier it will be to use. And so, things like the Achilles tendon and the patella tendon have been studied extensively for that because they're so easy to visualize with ultrasound. But there is a lot of conflicting data about both of those. And a lot of the issues is the heterogeneity and sort of methods and literature. And these things can be very much affected by patient positioning. So whether your knee is flexed when you're looking at the patella tendon or fully extended is going to affect the shear wave speeds.
Interesting.
And same with sort of the position of your foot if you're looking at the Achilles tendon. And so these all sort of have to be accounted for when sort of coming up with these methods. And I think for that reason, we sort of have a long way to go till we really have a firm understanding on how to use it clinically.